The second class on antibiotic. So in this I will be discussing about the beta lactams. Beta lactams. The structure of the beta lactam. So this is the structure of the beta lactam. So this is the structure of the penicillin molecule, and this is the beta lactam ring, and this is the thiazolin ring, and here you are having a side chain. So initially the first penicillin that was discovered was penicillin G. So this penicillin G, it was having the water solubility was low. So due to low water solubility, it was acting against only the gram positive bacteria and some gram negative bacteria. To make a wider spectrum, we decided to change the structure. We decided to make changes in the structure. As I have earlier said that we are having a gram positive bacteria as well as a gram negative bacteria, and the gram negative bacteria is having porins. Smaller molecule which are water soluble will pass through the porins more easily. So to make it more water soluble, we can actually remove this group. We can attack with an amidase, and after that we can add certain functional groups. So actually there are three functional group has been added. One is an amino group, another is a carboxy group, another is a urido group. So amino group means it is positively charged, carboxy group means it is negatively charged, urido group means it is both positive as well as negative charge. So when the ring is attached to the functional group, the ring it becomes ionized. That means it becomes more water soluble, so that now it can act against gram negative organism. The urido group, which is exerting both positive as well as negative, it is having the maximum effect towards the gram negative organisms. So by attaching amino group, we have synthesized amoxicillin and ampicillin. By attaching the carboxy group, we have synthesized carbenicillin, ticarcillin. Ticarcillin. And by attaching the urido group, we have synthesized azilocillin, mazilocillin, and piperacillin. Piperacillin. These two group of drug can be used against pseudomonas. And moreover, both these are given by parenteral route. Now about this piperacillin. So this piperacillin, it is a preferred drug and it is a penicillin of choice in case of pseudomonas, and it is also effective against listeria, enterococcus, Klebsiella, Klebsiella. Whereas this group, which is containing the amoxicillin and the ampicillin, it is taken orally, and this ampicillin can also be given as intramuscular route. Actually, the penicillin, that is all the penicillin, they are contra contraindicated with food, because the food will decrease the absorption of the penicillin, except there is an exception, amoxicillin. So amoxicillin, it can be given along with the food. It can be given along with the food. So in this amoxicillin and the ampicillin, amoxicillin is more preferred. It is because this amoxicillin can be given with food. It is having amoxicillin compared to ampicillin, amoxicillin is having better oral absorption. So due to this better oral absorption, there is a high peak plasma concentration in this amoxicillin, so that the duration of action, it is twice longer than ampicillin. So for an example, if the amoxicillin is given if the amoxicillin is given 3 times a day, ampicillin is given at 4 times a day, that is QID. And as amoxicillin is more absorbed, it is having more oral absorption, the diarrhea will be less. It is because, so when amoxicillin is having better oral absorption, there is less amount of drug that is reaching at the intestine, so that in intestine there is a normal flora. Actually in this intestine there is normal bacterial flora, so this antibiotic will destroy that normal microbial flora, and that will cause diarrhea. But as amoxicillin is having a good oral absorption compared to ampicillin, there will be less post antibiotic drugs that is reaching at the intestine level. So that means amoxicillin will cause lesser diarrhea compared to ampicillin, which causes more diarrhea. But the advantage of ampicillin is that the ampicillin is active against Shigella. So this ampicillin, it act against Shigella, whereas amoxicillin, it is not active against Shigella. The ampicillin, it is the drug of choice in Listeria meningitis and Enterococcus fecalis. So this amoxicillin and ampicillin, their spectrum. So their spectrum, it is similar to penicillin G. And compared to penicillin G, it is more effective against pneumococcus. This ampicillin and amoxicillin, it is more effective against pneumococcus. It is more active against the gram negative E. coli, Klebsiella, Salmonella, H. pylori, Enterococcus. So compared to the penicillin G, ampicillin and amoxicillin are more effective. So I have said that the amoxicillin, it is generally preferred over ampicillin. So we can use it in the H. pylori regimen. We can use in H. pylori regimen, and if there is subacute bacterial endocarditis, so we can give aminopenicillin with gentamicin. So it can also be given in case of urinary tract infections. It can be given in typhoid, but it is not preferred. Then we can give it in the respiratory tract infection. So we can give in such as bronchitis, sinusitis. Then we can give in meningitis. So in case of listeria, if it is causing meningitis, the drug of choice is ampicillin. So the meningitis is caused by listeria. The drug of choice is ampicillin. And if it is caused by meningococcus or H. influenzae, so the drug used is ceftriaxone. So in this ceftriaxone, it is a drug of choice. So if there is a meningitis infection and if the organism is not confirmed, so we can give this ampicillin and the ceftriaxone. So in Enterococcus faecalis, the drug of choice is ampicillin. So that I have mentioned earlier. So now few words about the penicillin G. So penicillin G, it will be acting as a narrow spectrum. That means it will be acting against gram positive and a few gram negative organism. So this penicillin G, it is having poor oral absorption. It is because this is acid labile. So actually the beta lactam ring. So this beta lactam ring, it is getting degraded in the acidic stomach. So this is acid labile. So we have changed the structure to make it acid stable so that we can give orally. So we have designed a drug that is called the penicillin V, and the spectrum of action of penicillin V is the same as penicillin G, except but it is less effective against the meningococcus. This penicillin G, it is also known as aqueous penicillin G, and it can be given IV, intravenously. So the penicillin G, it is a short acting. This penicillin G, it is a short acting. It is because there is a P glycoprotein pump. That is a P glycoprotein pump. So due to this pump, there is rapid tubular secretion. So there is rapid tubular secretion. So we have designed drug that inhibit this P-glycoprotein pump. So that is called the probenecid penicillin G. And we have also made it insoluble in the form of insoluble salt. So one is a procaine penicillin G and the other is benzathine penicillin G. So this all drugs, it will be acting intramuscularly. It is contraindicated in IV. So this is done to increase the duration of action, to make it long acting. So now about the benzathine penicillin G. So it is the longest acting penicillin, that is 28 days. It is the longest acting penicillin, and so it is a drug of choice for the rheumatic fever prophylaxis. In case of rheumatic fever prophylaxis, this is a drug of choice. So this is given once in a month. And this benzathine penicillin G, it acts as a drug of choice for syphilis, the streptococcus, yaws, gas gangrene, then rat bite fever, and leptospirosis. In case of leptospirosis, so in this I will be talking a little bit about this syphilis. So we have the primary in syphilis. We have primary syphilis, secondary syphilis, and latent syphilis. So in this condition, we can give this benzathine penicillin G, that itself intramuscularly 2.4 million unit once. So this is million international unit per once. In case of tertiary syphilis, if there is a tertiary syphilis with no CNS involvement, and if there is a tertiary syphilis with CVS involvement, or it is late latent syphilis, so we can give intramuscularly the benzathine penicillin G, benzathine penicillin G, and that itself 2.4 million international unit. So in this case, 3 doses are given once a week. So we will give 3 doses and it will be given once a week. In case of neurosyphilis, so in case of neurosyphilis, so we will give aqueous penicillin G, aqueous penicillin G, that is 18 to 24 million international unit, that will be given continuous IV infusion for 10 to 14 days. Then there is a reaction which is called as Jarisch-Hersheimer reaction. So Jarisch-Hersheimer reaction. So this is a hypersensitivity reaction that is seen with the penicillin use in secondary syphilis. So the person will present with, there will be fever, rash, then there will be arthralgia and worsening of the cutaneous lesions. Now, if a pregnant woman is having syphilis in a pregnant woman, so we will give benzathine penicillin G. Benzathine penicillin G. So if there is hypersensitivity, we will desensitize the patient with lower doses of penicillin and administer this benzathine penicillin G. Now about the penicillin resistance. About penicillin resistance. So we are having the gram-negative organisms. So what we are having two group of organisms. One is gram-positive, second one is gram-negative organisms. So especially in the gram-negative organisms, so outside the cell membrane there is cell wall. So in the cell wall there are porins. So through these porins, actually the penicillin binding proteins, so they are actually present. Actually these porins are present outside. That is, actually this is a cell. So this is actually the peptidoglycan layer, and outside the peptidoglycan layer there is an outer membrane where the porins are present. So the penicillin will have to enter through the porin to execute its action. So what the gram-negative organism will do is that it will decrease the porin production. So the decrease in the porin production, it is done by pseudomonas, and there will be penicillin resistance. This is one mechanism. There is another mechanism, that is they will be having a drug efflux pump. That means if the penicillin enters inside, it will be thrown out of the cells. So this mechanism is present in the Pseudomonas, E. coli and Gonococcus. So the next two mechanisms which I am gonna discuss, it is present in both gram-positive as well as gram-negative organism. So what the bacteria will do is that, so the penicillin will be binding onto the transpeptidase. So here you can see that beta-lactams, that is a penicillin, it will be binding to the transpeptidase, otherwise called as, this is also called as penicillin binding proteins, because these are bound. So this will be bind by the penicillin. So they will alter this transpeptidase or this penicillin binding protein. So this is actually seen in MRSA, that is it will be resistant to the penicillin, so it will be methicillin resistant Staph aureus. So this resistance transfer, the gene responsible is MECA gene. So this is responsible for this resistance. So another mechanism is the beta lactamase production. Actually, beta lactamase is an enzyme to digest this beta lactam group. So in the beta lactamase production, there is a classification that is called as Ambler's classification. So the Ambler's classification, it is divided into 4 groups, that is A, B, C, D. And in the group A, ESBL group are included, that is extended spectrum beta lactamase. So this group will produce penicillinase. So there will be penicillinase, cephalosporinase, and monobactamase. So here the drug of choice that we can use is carbapinam, because in the beta lactam group the enzyme to degrade the carbapinam is not produced. So carbapinam is a drug of choice. In the second group, that is the B group, all enzymes are produced except monobactamase. In the group C, there is C4 cephalosporinase. And in the group D, there is cloxacillinase. So recently there is a beta lactamase that is called as metallo-beta lactamase. So metallo-beta lactamase. So the NDM1, that is New Delhi 1 beta lactamase. So this will break all the beta lactams. It will bring all the beta lactams, the fluoroquinolones, then the chloramphenicol, the macrolides. So these bacteria, they are also known as superbugs because they are having a wide resistance. So they are treated with they can be treated with the colistin and tigecycline. So now we have to think how we can overcome this penicillin resistance by the beta lactamase. So we have used, for the drug which are used in penicillin resistance, we can use the beta lactamase inhibitors. So in this we will use the analog of beta lactam which competitively inhibit the beta lactamase. So they can also bind to the transpeptidase and it is having the antimicrobial effect. For example, the amoxicillin. So it is combined with a beta lactamase inhibitor, and that beta lactamase inhibitor is clavulanic acid. So this is a beta lactamase inhibitor, clavulanic acid. So we can combine the ampicillin with sulbactam. So this is a beta lactamase inhibitor. Actually this sulbactam alone, it can be used to treat Acinetobacter. Acinetobacter. This sulbactam alone. And the piperacillin we can use with tazobactam. Tazobactam. So this is a penicillin of choice. This is a penicillin of choice for ESBL organisms. That is extensive spectrum beta lactamase organisms. Then we can combine the ceftazidime with the avibactam and meropenem with the vaborbactam. Then we can combine the imipenem and hilastatin with the relibactam. So these are the combinations. So the second mechanism we have done is that we have penicillinase resistant penicillin. That is a penicillinase which are resistant to penicillin. So we have actually changed the structure. Actually this penicillinase, it will be this penicillinase, it is actually breaking this beta lactam ring. So we have changed the structure. So we can change the structure of the R group, and we have made the penicillinase resistant penicillin. So it is also known as anti-staphylococcal penicillin. So through oral route we can give the cloxacillin, dicloxacillin. So this penicillinase resistant penicillin we can give through the oral route, that is cloxacillin, dicloxacillin and oxacillin. So these are used for mild to moderate local infections such as cellulitis, mastitis. So we can treat such local infection. Actually oxacillin, this is hepatotoxic. So it is only which is hepatotoxic penicillin, this oxacillin. And through the parenteral route we can give nafcillin, oxacillin and methicillin. So the parenteral route, it is given in severe infections such as endocarditis, but this nafcillin, it causes neutropenia, and the methicillin, it is not used clinically. It is due to it causes interstitial nephritis. It causes interstitial nephritis. So when we were using the penicillin against the Staph aureus, so we are having this Staph aureus. So they changed the transpeptidase, or they altered the penicillin binding protein, and they became MRSA, that is methicillin resistant Staph aureus. So we used, for MRSA, the drug of choice was vancomycin. So this was the drug of choice. So when IV vancomycin was given, this MRSA, so it was acting to the alanine ligase and alanine racemase. So they changed their structure from D-alanine to D-lactate, and they become resistant to vancomycin, that is VRSA. So these two was cell wall synthesase inhibitors. But now we don't have a choice to act on the cell wall. So we have on VRSA, the drug of choice, it is a cell membrane active agent, that is daptomycin. So in case of MRSA and VRSA, we can use other drugs such as the protein synthesis inhibitors such as tigecycline, linezolid, then streptogramins. And in the case of MRSA, for the skin and the soft tissue, we can use a fifth generation cephalosporin, that is called as ceftaroline. It is a fifth generation cephalosporin. Then we can use drugs such as doxycycline, minocycline, cotrimoxazole, and other glycopeptides. So this is all about the penicillin.